Good afternoon. It's a pleasure to be here. And my name is Dr. Karen Gavet. And I'm in the Department of Radiation Oncology at Emory University, where I've been for many years. Trying to get rid of the echo. Here we go. So as I said, I'm a radiation oncologist at Emory, and I'm talking to you today about our intraoperative experience. Now, this is an old slide, but it just goes to show you the illustration of the patients that have breast cancer that get radiation versus those that don't. So there are many ways to treat breast cancer. You could have a mastectomy or a lumpectomy with or without radiation. And many patients who are eligible for a lumpectomy actually do not get radiation. And many of those patients end up getting mastectomy because they do not want radiation. Now, this is a timeline which shows the milestone with regards to surgery and radiation over several years. In the 1800s, you had a radical mastectomy where you can see that all the muscles beneath the breast were removed. You can just see the ribs. And that was in the 1800s. And finally, in the early 1990s, they decided to try breast conservation. That was after we did less surgery here, as you can see, with a modified radical mastectomy. With breast conservation, the studies showed that if you remove the lump, you can have the same effect of a mastectomy once that surgery was followed by radiation. In terms of the timeline, initially a radical mastectomy was used, where you can see that the surgeries was, as it's called, pretty radical. The muscles beneath the breast were removed, and it resulted in a significant deformity. And that then we got to a modified radical mastectomy, which was a little less so. Later on, around 1995, we had studies that showed that breast conservation, where you remove the area followed by radiation, patients did just as well with as a mastectomy. Now, with those studies, we treated the whole breast in its entirety and sometimes the lymph nodes. And you can see beneath here, you have the breast, you also have the lung, and if you go a little bit lower down, you'll have the heart. A decision was made to see maybe we can treat just part of the breast. And what happened is, in these cases, we treated the whole area of the breast and delivered a boost to the area of the lumpectomy site. And you can see here, this looks pretty gruesome, but these are plastic catheters that are placed in the patient's breasts. And this is another way of delivering partial breast radiation, which is a balloon catheter. And now we're talking about intraoperative radiation, which is the biggest studies. The target trial was in 2000. And this is what we're talking about today. So we went from drastic surgery to now conservative surgery as well as conservative radiation. And how did we decide to do partial breast radiation? The reason for this was that in the majority of cases, it was found that breast cancer, this should be 90%, sorry, that 90% of the current recurrences actually happen in the area where the initial tumor was, and less likely to occur in other parts of the breast. So most of the breast recurrences are where the tumor was. And that was the reason for partial breast radiation. And with intraoperative radiation, we are delivering the radiation to the area after the surgical excision. So right exactly in the spot. There's no means of missing the area where the surgeon did the surgery. So what are the benefits of intraop? Of course, it's a shortened treatment time, and we're talking about a single treatment rather than the daily treatments of radiation. Standard radiation, although now we can cut it shorter to it's between 4 to 6 weeks, but it's still 10 minutes to 15 minutes a day, Monday through Friday, getting back and forth to the hospital. With intraop, we're doing one single treatment. Because we're not treating a lot of the breast, we're having decreased side effects on the other structures, such as the skin, the heart, of course, the lung, which is more important, and the ribs. Because you're not going back and forth, you're less likely to be fatigued, and you're more likely to be able to get back to your regular activities of daily living because it was a one-day procedure. So you're just really basically recovering from the general anesthesia more than the radiation. It's also less expensive. A single treatment is a lot less expensive than being treated for 4 to 6 weeks of external beam radiation. And it's also less of a hassle. It's more convenient. There are many patients now that we can treat because they're coming from a great distance to the center and would not be able to make that over a 6-week course. They can do this in a one-time treatment. And there's some patients that I meet who are turned off by coming daily for radiation, but are willing to accept a one-time treatment. There are a lot of myths surrounding breast cancer radiation, and so it's great to have an opportunity to offer this to some patients who would otherwise not get any radiation treatment when it's needed. And if you do have to have systemic therapy, like systemic therapy, I mean chemotherapy, you'll get started quicker if we did the intraop radiation. And like I said before, we are putting radiation in areas of highest risk for disease or a highest risk for recurrence. And there is some suggestion from the studies that you're less likely to get a second malignancy actually from the radiation doing intraop versus doing it with the external beam radiation. And since we're talking about COVID, this would be a logical response to COVID rather than having to come to the hospital and being exposed to other patients and just getting there and the hassle, but more the exposure to COVID by the repetitive visits to the doctor. This would be a logical response, a single treatment. In the Emory program, how do we get started? Like everything else for breast cancer in this area, Dr. Phillips was the one that pushed and initiated this program. She came to me probably like 2013. It took us a while to decide, which equipment we wanted to use, what system we wanted to use. But it was Dr. Phillips, at Dr. Phillips' urging, that we started the Emory IORT program. Our first treatment was in October of 2015, basically 5 years ago, and to date we've treated over 200 patients. Most of our patients come from referrals within the state, but we also have some patients who come from outside the state, and there's some patients who looked us up in YouTube and found the program that way. And this is a team that's involved. The patient first has a mammogram, and that's going to be done like all these people you would have heard from today. The breast radiologist who's looking to see if it's a malignancy or not, and if it's early or not. The pathologist is the one that's reading the slides, and then the patient gets sent to the surgeon. In more advanced cases, the patient may start with the surgeon and then go to the breast radiologist and the pathologist. After the surgeon sees the patient, then the patient is sent to me ahead of time to see if I think the patient is a good candidate for intraoperative radiation. I'll tell you the criteria that I use to decide that. And then after that, if need be, the patient is sent to a medical oncologist for any other systemic or endocrine therapy. So what are our selection criteria? The main thing is that while intraop is available here, it's not something that should be given to every patient. Our inclusion criteria is a patient older than 50 years who has a breast cancer that is less than or equal to 3 centimeters, that is hormone positive. You heard about that earlier today. And with what we call negative margins, meaning there were no cells left behind after the tumor was removed. There's no signs of the cancer in the blood vessels. There's no sign of cancer in the lymph nodes. And if there's DCIS, which is not an invasive cancer, it should be lower intermediate grade. So there are some patients that we would not treat. The patients with a lobular carcinoma, which is a cancer that's most likely, that can also show up in other parts of the breast. A patient who has to have chemotherapy first. A triple negative breast cancer, you heard about those patients who they are more aggressive tumors and we're not likely to treat them with partial breast radiation. And patients with BRCA1 or 2 and patients where the cancer is genetically transmitted. There are some patients where we have to decide when we're in the operating room, depending on the size of the breast, where the cancer is in the breast and the grade. If the patient has a high grade DCIS, if it's small, we will sometimes do it. And the same for a patient with small breasts. And this just shows you some of the patients that we've had in the past. And this is an analysis of the first 100 patients that we have. The majority of this is basically saying 70% of the patients were African American, a third of them Caucasian, and the lesser extent Asian. Most of the cases, the tumors are in the upper outer quadrant. And of course, we're talking about early tumors, of which only about 10% of them were between 2 and 3 centimeters. All the rest are less than 2 centimeters. And what are some of the side effects of intraoperative radiation? You may get some mild swelling or pain at the surgical site. Of course, anytime you have surgery, you're at risk for infection. There may be some redness or tanning of the skin over the applicator, some firmness of the breast. And sometimes there's what we call a seroma, which is a fluid collection at operative site. Rarely we get wound breakdown or wound dehiscence. Later, sometimes the patient has a feeling of firmness at the biopsy site, which is secondary to damaged fat cells. And like I said, there is a chance of cancer due to radiation, any type of radiation exposure, but it's a lot less with IORT. And this is just a reminder, though, that although we do give IORT, intraoperative radiation to the breast, there are some patients who are going to require whole breast radiation after. If for some reason the cancer is larger than we think, if there's some cells left behind, and if for some reason the tumor appears more aggressive than we think or there are lymph nodes involved. Now, how do we follow these patients up? In 10 to 15 days, we review the pathology. We see if there's any additional radiation that is needed. And the one thing to remember is even if you do need whole breast radiation after this, the treatment that you got in the operating room removes a week off of the daily radiation treatment, so all is not lost. A diagnostic mammogram is done every 6 months for 2 to 3 years, and an MRI as needed. Like I said, if you do need radiation, sometimes it's over 5 weeks. Like I said, no boost is delivered, or we now do what we call hypofractionated. We treat the patient in 3 to 4 weeks instead of 6. The results of the target trial, I'm not going to go through because Dr. Small just did that. But the bottom line is there's no statistical difference between the patients that got intraoperative radiation and the patients that received external beam. The recurrence-free survival was the same. The mastectomy-free survival was the same. The overall survival was the same. And there's some suggestion that these patients actually lived a little longer. So the bottom line is it's a great opportunity for patients with early stage breast cancer. We will assess you to see if you are an appropriate candidate. And if so, we will proceed. And sometimes we do have to give whole breast radiation after, but it is a great option for some patients. And of course, we can only do it if the breast cancer is discovered early. So I urge you to make sure that you stay up in your mammograms because early detection, of course, gives you this opportunity. And I just want to show you, I'll end with this showing of, let's just see. Okay, it's not working. It's not working, but I actually had a quick video here just showing you our first patients and how that turned out that we treated 5 years ago, who's doing actually just fine. Again, I want to thank you all for your attention. Sorry for the audio difficulties at the beginning. I'll be happy to answer any questions. Thank you.